Okay, this is chapter 49 of NUR 203, neuromuscular or muscular dysfunction. CP or cerebral palsy definition is a group of permanent disorders of the development of movement and postures causing activity limitations that are attributed to non-progressive disturbances that occurred in the development or developing fetal or infant brain. These statistics are from 2008, and I understand they have not changed much, so in spite of modern technology, some things are just unavoidable and unpredictable, like motor vehicle accidents, intimate partner violence, and new viral infections like we're dealing with now. CP used to be thought to have been caused by perinatal problems, but now after decades of research, it's believed to be the result of existing prenatal brain abnormalities. 70, not 80% of CP is caused by unknown factors. Prenatal brain abnormalities would include things like gross abnormalities of the brain, vascular occlusion, laminar degeneration, effects of low birth weight, anoxia, and hypoxic infarction or hemorrhage. Clinical classifications would include motor abnormalities like functional motor disabilities, associated impairments that would include seizures, hearing and vision impairment, behavioral, communication and speech problems, anatomic and radiologic findings like white matter lesions, causation and timing postnatal events include things like meningitis and traumatic brain injury. Diagnostic evaluation of CP, infants at risk require careful assessment during early infancy. Neurologic examination and history, primary means of diagnoses, is on page 1457, box 49.3. And of course they would do imaging and metabolic and genetic testing. Clinical manifestations of CP, page 1457, box 49.2. And you can see all of these listed there. Goals of therapy for CP, of course, the main one would be to establish locomotion, communication, and self-help skills. We want them to function at the peak of their possible abilities, to achieve optimal appearance and integration of motor functions, to correct associated defects as effectively as possible, like cutting the back of the heel when they have tight Achilles tendons so that they can walk on their feet with assistance, to provide educational opportunities adapted to the child's capabilities, and to promote socialization experiences. Therapeutic management: ankle-foot braces may be worn, orthopedic surgery to correct spastic deformities, pharmacologic agents to treat pain-related spasms and seizures, botulism toxin A injection, botulism is spelled wrong, sorry, dental hygiene, physical and occupational therapy. And this is a very happy child with his mobilization device. Bike walker, used to provide mobility and to enhance leg strength muscle. Prognosis of CP depends on the type and severity of the condition. Moderate impairment, 85% of the patients can achieve ambulation. Cognitive impairments in 30 to 50%. Growth is affected. Survival dependent on comorbid conditions. Care management, assisting the family in devising and modifying equipment and activities. Medication administration, safety precautions, recreational activities, physical, speech, and occupational therapy, and support of family. Manual jaw control provided anteriorly for when the child needs medication or feeding. And this one is showing manual jaw control provided posteriorly. Neural tube defects. This is the largest group of congenital anomalies. Normally, the spinal cord and cauda are encased in a protective sheath of bone and meninges, 3 layers of meninges. Failure of neural tube closure produces defects of varying degrees. The incidence is 0.3 per 1,000 births. Occurs more often in white or Caucasian and Hispanic children. Types of neural tube defects, box 49.4 in your chapter, significant neural tube defects, talks about anencephaly, myelodysplasia, spina bifida occulta, spina bifida cystica, and meningoceal and myelomeningoceal. And this is a picture showing spina bifida occulta. In the B picture, the normal spine, in the A picture, of course, meningoceal in C and myelomeningoceal in D. Left, the A picture, you have meningoceal with an intact sac, and the B picture, you have a myelomeningoceal with a ruptured sac. Usually around 20 days after conception, the neural tube formations begin to form, and more often than not, it is before we even know that we're pregnant that these deformities have already formed. Folic acid is very important in our diet to help prevent this from happening. Eating well during the time in which you're in your reproductive years is super important, and take those prenatal vitamins as early as you think you might be pregnant. Failure of the neural tube to close during the embryo's early development, approximately 3 to 4 weeks of after conception. There may be multifactorial causes, genetic mutations, and additional factors include maternal obesity, maternal diabetes mellitus, and low vitamin B12 levels. At 16 to 18 weeks, if you have good prenatal care, the doctor will want to do blood work, which often shows genetic abnormalities, and then an ultrasound would be done. The purpose of this is so that the woman so that the woman would find out early enough in her pregnancy to have an abortion. But all that's changing now, as states are changing laws to prevent abortions for any reason or for specific reasons, so you have to check your state's abortion laws. But that blood work is still done, usually around 16 to 18 weeks. Chorionic villi sampling is the earliest test that can be done, not before 10 weeks, but about 10 weeks of gestation, that will let you know if you have a baby that has abnormalities genetically. Most surgeons believe it's best to close within the first 24 hours when you have an open neural tubal defect, especially if the sac is leaking CSF fluid. When this is discovered early in prenatal care, they can do some surgery in utero to help correct and prevent hydrocephalus in the fetus. This often helps with improvement in motor and mental function when the infant is born. Management of genitourinary function is on page 1464, and these children often have a latex allergy. Bowel control is often through an ostomy, and the prognosis depends on the severity and how early the treatment is. So, children are very adaptable, and they are amazing at recovering from things, so don't underestimate them. Prevention of neural tubal defects, we already talked about. Women in childbearing age should take folic acid or have folic acid at least 0.4 milligrams per day in their diet. If you have a history of neural tubal defects, you need 4 milligrams per day in your diet. Cereal grains fortified with folic acid as required by the U.S. Food and Drug Administration since 1998. And you can take supplementation. which should begin before conception. It prevents 50 to 70% of all cases. In the care management of these children, you want to keep the infant prone and cover the sac with a sterile, moist, non-adherent dressing, and keep it moist so that it does not stick. Place the infant in an isolette with temperature control. Do not do rectal temperatures, only axillary. Monitor for rupture of the sac and for signs of increased intracranial pressure. Maintain the legs in an abducted position. Diapering is prohibited until the defect is corrected, so we would usually just slip the open diaper underneath them to kind of pad under them whenever they do have a bowel movement or some urine. Dressing changes every 2 to 4 hours. See page 1467, box 49.6, medical conditions associated with latex allergy, and also the guidelines for identifying latex allergy. We want to carefully clean the sac, prevent complications, provide post-operative care, and support the family and educate them about home care and allergies to latex. Spinal muscular atrophy type 1. This is a disorder characterized by progressive weakness and wasting of skeletal muscles caused by degeneration of the anterior horn cells. It is inherited as an autosomal recessive trait and is the most common paralytic form of the floppy infant syndrome, congenital hypotonia. Wernicke-Hoffmann disease. Autosomal recessive trait, most common paralytic form of floppy infant, known as congenital hypotonia. Progressive weakness, wasting of skeletal muscles, variable age at onset is usually before 2 years of age. It manifests within the first 2 months of life. Infants lie in the frog leg position, have a weak cry, cough, and generalized weakness. Active movement usually limited to fingers and toes. Normal sensation and intellect. Unfortunately, death usually occurs before age 2. Diagnosed by electromyography and muscle biopsy. Treatment is just symptomatic. Prevention, vigorous treatment of infection, treatment of orthopedic problems, especially scoliosis, and the prognosis varies with age of onset. Spinal muscular atrophy type 3. This disease is a result of anterior horn cell motor nerve degeneration. The disease is characterized by a pattern of muscular weakness similar to that of type 1 SMA. See box 49.7 on page 1468. Clinical manifestations of spinal muscular dystrophy. Kugelberg-Weilander disease. That's what type 3 is called. Onset from before 1 year of age to adulthood. Symptoms similar to those of spinal muscular atrophy type 1. Muscle weakness and muscular atrophy. Ability to ambulate lost by adolescence. And life expectancy may actually be normal. Duchenne muscular dystrophy, DMD, is the most severe and most common MD in children. It is inherited as an X-linked recessive trait, and the single gene defect is located on the short arm of the X chromosome. It's also called pseudo-hypertrophic muscular dystrophy, most severe and most common of the dystrophies in children. X-linked inheritance pattern, incidence is 1 per 3,600 male births. This is the initial muscle groups involved in muscular dystrophies. Page 1470, box 49.8 tells you about the characteristics of Duchenne muscular dystrophy. And see box 49.9 on 1471 for the clinical manifestations of Duchenne muscular dystrophy. Diagnostic evaluation, prenatal diagnosis as early as 12 weeks of gestation. Established primarily by blood polymerase chain reaction for dysmorphic chain mutation. Confirmation of this is by electromyelography, muscle biopsy, and serum enzyme measurements. Positive family history and display of usual characteristics of the disease. They will have a waddling gait, frequent falls, and Gower sign. There is pictures in your book of the child showing Gower sign. Please pay attention to how that is and how it's described. Lordosis, enlarged muscles, especially in the thighs and upper arms. Profound muscular atrophy in the later stages, mild to moderate mental impairment, and obesity. There is no curative treatment. The use of corticosteroids like prednisone and deflazacort has been evaluated as a treatment. Some children respond to these drugs positively, but some do not. So the primary goal is to maintain function in unaffected muscles as long as possible. Keep the child as active as possible. Do range of motion exercises, bracing, performance of activities of daily living, surgical release of contractures as needed, and genetic counseling. Interprofessional team management is a combined effort for those children and the parents with DMD. Nurses become very involved in the primary part of the team because they get very close to the child and the family. So when something happens to these children, naturally, as caring professionals, we're going to be upset. That's perfectly normal. On page 1473, box 4910, clinical manifestations of Guillain-Barré syndrome, also called infectious polyneuritis. Acute demyelinating polyneuropathy with progressive paralysis. Children less often affected than adults, but there is an occurrence in children, most often between ages 4 and 10 years of age. Pathophysiology, immune-mediated disease, often associated with viral or bacterial infections or administration of vaccines. There are 3 phases. The acute phase starts when symptoms begin and continues until new symptoms stop appearing or deterioration cease. It may last as long as 4 weeks. Then they plateau, where the symptoms remain constant without any further deterioration. It may last from days to weeks. And recovery, the patient begins to improve and progress to optimal recovery. It usually lasts a week to months, depending on the deficits that occurred by the illness. Hospitalization due to respiratory and pharyngeal involvement may need a ventilator in some cases. IVIG and steroids will be used for treatment, and plasmapheresis has been shown to decrease the length of recovery, but this is expensive and has many side effects like hypotension, fever, bleeding disorders, chills, urticaria, and bradycardia. So not a lot of people just wait it out and don't opt for that. Initially, there's muscle tenderness, paresthesia, muscle weakness. Again, refer to box 4910. Paralysis rapidly ascends from the lower extremities. May involve the trunk, arms, and face. Then there will be flaccid paralysis and loss of reflexes, intercostal and phrenic nerve involvement, and in many patients there's urinary incontinence or retention and constipation. The treatment is symptomatic, possibly steroids, IV, IG, and plasmapheresis, respiratory support, even ventilators if needed, medications to support and prevent complications, and there are 3 phases: acute, plateau, and recovery. Better outcomes are associated with younger children. So the younger the child is that has this, the better chance of recovery completely. Most patients have complete recovery. In most patients, muscle function begins to return 2 days to 2 weeks after onset of symptoms, but there's a period to complete recovery, can be prolonged. Most deaths caused by respiratory failure. They need supportive care, observation for early signs of respiratory distress and difficulty swallowing. They might need temporary urinary catheterization, prevention of complications, pain management, physical therapy, and support of the child and family. Tetanus, also known as lockjaw, this is often a fatal disease caused by an exotoxin produced by anaerobic spore-forming gram-positive bacillus, Clostridium tetani. This is characterized by muscle rigidity involving the masseter and neck muscles. That's in the face and neck. That's why it's called lockjaw, I guess. Spores are found in the soil, dust, and gastrointestinal tract of humans and animals. The bacteria enter the body through wounds, especially puncture or crushing wounds or burns. And if you step on a nail, if it's rusty, or you get scratched by a wire that's rusty, you need to be particularly aware of that. Bacteria may enter through scratches, bee stings, thorns, or needle prick. Risk for exposure is greater during outdoor activities. 4 necessary conditions for developing tetanus: presence of tetanus spores or vegetative forms of the bacillus, injury to the tissues, wound conditions that encourage multiplication of the organism, and the susceptibility of the host. So immunization is the primary preventative measure. Once an injury has occurred, further preventative measures are based on the child's immune system and the nature of the injury. So specific prophylactic therapy after trauma is administered through a tetanus toxoid and tetanus antitoxin. See page 1475, box 4911 for clinical manifestations of tetanus. And all of these are there. So clinical manifestations would also include respiratory, accumulated secretions, atelectasis, pneumonia, respiratory arrest, patient anxious but alert. Mentation seems to be unaffected, rapid heart rate, diaphoresis, mild or no fever. Incubation is 3 to 8 days, and survival beyond 4 days is usually an indication that they will recover. The disease is prevented by the tetanus toxoid or tetanus antitoxin after exposure, or getting your tetanus immunization as a child and your boosters at least every 10 years. Treatment of wounds contaminated with dirt, feces, soil, saliva, puncture wounds, avulsions, crushing, burns, frostbite should include tetanus immune globulin if the patient is inadequately immunized. They'll be in the intensive care unit for constant observation and respiratory support, monitoring of fluid electrolyte status, tetanus immune globulin therapy to neutralize the toxins, wound care to decrease proliferation of the organisms, and muscle relaxants, sedatives, and Pavulon, which is a paralytic. They don't really use that too much anymore. They've gone to propofol, which is used more currently. Also a paralytic, the one that actually took out Michael Jackson. So we need to control environmental stimuli, pay particular attention to the airway and breathing. Total paralysis may be induced. Attempt to reduce anxiety of the child and family. Then we have botulism, food poisoning resulting from ingestion of toxin produced by the anaerobic bacilli Clostridium botulinum. Sources in older children, improperly sterilized home canned foods, and in infants, honey and light or dark corn syrup. Clinical manifestations of botulism, central nervous system symptoms appear abruptly within 12 to 36 hours after ingestion. General signs: weakness, dizziness, headache, diplopia, speech difficulties, and vomiting, and progressive, life-threatening respiratory paralysis. Treatment: administer IV botulism immune globulin. Provide supportive measures, respiratory support, nutritional support, and continue therapy until the paralysis abates. Honey should never be given to an infant under the age of 1 because they are more prone to getting botulism than an older child. So, caused by ingestion of spores or vegetative cells of C. botulinum and subsequent release of toxin. Wide variation in severity of the disease can be mild constipation to respiratory failure. Spinal cord injuries. Generally the result of indirect trauma like motor vehicle crashes, sports injuries, birth trauma, non-accidental trauma, hyperflexion or hyperextension of the neck. Levels of spinal cord injury, see page 1477 for more about all of these listed here. Therapeutic management begins at the scene of the injury with proper immobilization of the cervical, thoracic, and lumbar spine. Stabilization and transport to the pediatric trauma center environment. Functional electrical stimulation. Care management is complex and challenging, and it takes a multidisciplinary team. Therapeutic management. This is a wheelchair that allows an adolescent mobility and independence to get around. During the recovery and rehabilitation phase, patients with SCI must carefully be monitored for complications of immobility, such as DVT and pulmonary embolism. Children with high-level lesions are susceptible to the development of autonomic dysreflexia, which requires prompt action to prevent encephalopathy and shock. Clinical manifestations of this include a drastic decrease in systemic blood pressure, headache, bradycardia, profuse diaphoresis, cardiac arrhythmias, flushing of the skin, piloerection, blurred vision, nasal congestion, anxiety, spots in the visual fields, and or absent or minimal symptoms. So care management is on pages 1479 to 1480, and we're going to, of course, above all, ensure a patent airway, and all of the rest of these things here you can read for yourself. Now you have a progressive infantile spinal muscular atrophy, and the most common paralytic form of the floppy infant syndrome would be which one of these? And if you recall correctly, it would be C, the Werdnig-Hoffmann disease, a disorder characterized by progressive weakness and wasting of skeletal muscles caused by degeneration of the anterior horn cells, and the most common paralytic form of the floppy infant syndrome or congenital hypotonia.